of them are PhDs in tissue bioengineers. I call them nerds. And they teach us orthopedic surgeons all about the basic science and what's happening in the future. The other half are the best sports medicine doctors throughout the world that are applying some of these new defects. The scene down over here, this is the Clinica Centro. Right now, this is in Madrid. It's 100, and it will be in December, 160-bed orthopedic hospital. We're 130 beds right now. It's an orthopedic hospital. In 2009, just to let you know, we did 1,081 anterior cruciate ligament injuries. It's where the football players in Spain go for their treatment. And if you come to our clinic, you play next year. But we have a vast, vast amount of orthopedic experience. We also have a bioreactor in the hospital where we grow our own chondrocytes and grow our own cartilage, grow our own cruciates. So we'll talk a little bit about that as what's happening and where we're going. Here we are now. ICRS, again, we're jointly sponsored. This is in conjunction. Everybody here is a member of the ICRS as well as SICOT. Doesn't want to move so quick. What I'm going to talk about is not FDA approved in the United States, and none of us here get any financial benefit from this. The fellow in the center, Lars Peterson, is why we're all here, because before him we really couldn't culture chondrocytes in humans in a predictable way. The other guy is Dr. Guillen, and the ugly old guy on your left is me. I'm a ski doctor in Lake Tahoe, but I don't think it's going to move, so we'll just move on. Oh, wait, it is. Doesn't want to move, does it? Can you make that move? No? Okay. Well, we started this, we had done 152 ACIs and 174 MACIs, and now we have 41 of the next generation, the third generation that we've moved on to, and we'll talk about why. We do like cultured chondrocytes so far. That's the best substance that we've used to try to regenerate cartilage, and we'll talk about what else we've used. The ACI we've talked about. Lars Peterson, at 20 years, if he was here, was going to tell us that in an isolated medial femoral condyle lesion at 20 years, you have between 85 and 90% success. And taking all comers with bipolar lesions and these god-awful lesions, he's got about 80% success, including the patella. Am I supposed to be aiming this back at you? Because it doesn't want to move. Oh, there we go. It's real slow. And in our ACI that we did, we were at 95% with good to excellent result. 5% went on to other procedures, but 82 were really excellent and returned to full activity. 13 were just okay. The problem with the ACI, though, was that you have this periosteoflap hypertrophy, and this is one of our Real Madrid soccer players who actually had an ACI and then delaminated. And this delamination is one of the potential problems. When this was biopsied, it showed periosteum all the way, so it never did incorporate any of the chondrocytes. So with that in mind, we decided to move to knowing that this literature, you can take a collagen-covered membrane, then you put the cells underneath. It was being done. But at the same time, they found out that you can apply the cells to the membrane. These are just showing that you can use the membrane, and you can apply the membrane and you use a bioabsorbable scaffold or a matrix. And what we're using with this MACI was a purified porcine collagen, 1,3 type collagen, and it's bioabsorbable in 3 to 6 months. The chondrocytes are seeded onto the membrane, and you can see the green on the electron microscopy represents the chondrocytes. The membrane we talked about, it's got a smooth and a rough surface. It's a porcine collagen type 1, type 3. We're really not supposed to mention brand names, but this is commercially available. And this is just showing our chondrocytes. When we take the membrane with the chondrocytes on them, then culture them up, we can see that the chondrocytes actually do grow for us. And this is on the membrane that comes from the company. We also want to make sure in our own samples that we could do that it would happen. Again, the membrane's a porcine 1,3 collagen. The telopeptides have been removed, so it is totally allergenic. non-antigenic, it will resorb, it's bioabsorbable. And the membrane has excellent tensile strength. Now, hopefully this is going to move. Yeah. Well, what we wanted to show with this is that the membrane will move very, very nicely. It is flexible. It holds these 5/0 sutures. Down below, there you go. So you can see the membrane will move and will hold suture and will hold 3 or 4 hemostats. We'll see. Can you advance? Because I just want to play that real slowly. Go to the next one. There's a video of the membrane moving, but it doesn't want to do. What actually happens, though, is that we use a fibrin glue with the MACI membrane, and within the first 24 to 48 hours, and certainly by within a week, most of the cells start to migrate from the membrane through the fibrin glue, and then right away from the fibrin glue, by 3 weeks or so, it moves towards the subchondral bone. So the glue, the cells start migrating away from the membrane almost immediately, and it's a very good substrate to use. And we might be able to just play with the membrane itself. At 48 hours, you can actually see that the chondrocytes are in the glue. And then at 15 days, you can see also that it's in the glue and very little on the membrane. And then by 21 days, you see that there's a mix of mesenchymal cells and mesenchymal tissue and fibrous tissue in your subchondral region with very little in the membrane left. And at 6 months, you've got basically cartilage in your membrane is just about all gone. So the stuff stays, it starts to reproduce, it starts to make extracellular matrix. You've got to take your biopsy the same way as you would do for an ACI. And so your biopsy is about the size of an extra strength Tylenol. It's supposed to be 200 by 300 milligrams weight, about 5 by 10 millimeters. If you do an ACI, autologous chondrocyte implantation, with the liquid, you get 12 million cells in a 0.4 milliliters. If you use the membrane, the MACI membrane, you get 1 million cells per square centimeter. The membrane measures 5 by 4 centimeters, so you get 20 million cells on a 5 by 4 membrane. And the MACI, you need to suture the periosteum. The ACI, you don't. You just put the patch on directly. The indication, you have to have a big chondral lesion, no loss of the bone, normal anatomical alignment, and relatively young age. It really doesn't work after about 50 years of age. You want to measure your defect, you excise your defect, and then you'll put your membrane, you'll cut the size, and then we just use fibrin glue to place it on. Now, if it's unstable, we'll use, if it's unstable, we'll put suture as well. And at the end, you curate the defect, and all of these have these very stable rim, the same way that Ulrich described with this punch. And at the end, you wind up with this membrane that looks like that. Now, if you see any corrugations on your view up over there, that corrugation is not in the membrane. That corrugation is the gauze pad in between the rubber glove of your thumb and the membrane and holding it in. Have to hold it in for 5 minutes. We like arthroscopic implantation, though, of the autologous chondrocytes, because instead of the big incision, we can go to basically arthroscopic incisions. And at Semtra, we developed multiple arthroscopic techniques, and they've been presented in international and national symposiums already. They've been written up in journal. This is 2006, October. And this past May, last May of 2010, Arthroscopy Association North America, in the ankle edition, which you can actually buy out of here at the Bookman, has a copy of our article on how to do this in the ankle joint, which is the same as how to do it in the knee joint arthroscopically. Originally, we tried to do it freehand, and it really didn't work out too well. It became kind of a cluster you-know-what, and the membrane would flip up and down, and you wouldn't know which side had the cells on it. So we started to develop some arthroscopic methods and ways to do it. This can't be much slower. And what we did was, by taking suture anchors, you can then place the membrane on the suture anchors, put your fibrin glue arthroscopically, as you see over here, and then you can tie the knots, or if you don't know how to tie knots arthroscopically, you can put in a fibrin glue and just hold pressure on it and let the glue set. We also developed other instrumentation to make it even easier. So you need a nice big cannula to get it in. And then we first started pushing the membrane in, but we then started to use a suture anchor, and then we just started using nitinol wire. These, oh, look, it's running. So you want to drill your anchor in if you're going to use an anchor. And you know, if you do the open ACI procedure and you don't have enough area, you'll also put a suture anchor in. So putting a suture anchor in is not too bad. Now this shows you how you put the glue in, and then that's not going to want to. It would just save time. You can then tie the knots and put some more glue in, and your final product will look something like this arthroscopically. And this will move, but we'll move on. But now, to make it even easier, we developed these other instruments, and essentially you can just take your membrane, skewer it on this nitinol wire over here, put it through various cannulas. This will measure the defect, and then press it down. So we developed all kinds of arthroscopic instruments to do this arthroscopically. And these are articulated down over here so that you can go over the curvature of the femoral condyle. The instrument kit is only this. It's nothing very elaborate. And you can measure. It's not going to, nothing wants to move today here. And you can either use a ruler, but we developed, instead of the ruler, I'm going to move in a small space, we developed an arthroscopic caliper so we can measure the defect using the arthroscopic calibers. Maybe you'll have a better luck advancing them than I am, because this thing wants to go so slow. But you can see how the caliber works like that, and then the next picture is going to go real slow too. See how good it works? Maybe you'll advance it because I'm pressing, or maybe you just need new batteries on this at this point. In order to get the membrane down, instead of using a very fancy suture, you can just take a nitinol wire, or just a K-wire, put it in the center of your lesion, and then thread your membrane down over the K-wire, much as it looks like in the right scene over here. Do you want to advance, please? And anyway, then you can set down the membrane, and we have a pressing device that will hold the membrane pressing. Please pass to the next. Venga. So this is without the animation. This is just how the procedure is done. Measure the defect, create your defect, and then the various bone tamps to tamp it down to do it arthroscopically. It looks something like this with the nitinol wire, and you don't have to use the sutures as we showed originally. And then you just fiber and glue. Now, to make it even easier, we've developed a suture inserter that you can, works almost like a sewing machine type of thing to throw in these sutures. If you suture your periosteum, if you do ACIs, you know that one of the hardest things to do is to get the periosteal sutures really, really well. So if you use a glue, this can be done very simply, and you can do your sutures in just a couple of minutes. It takes longer to thread the little machine than it does to put the sutures in. But it can also be used arthroscopically to put with the glue. So you can just get your membrane in, put the glue. If you feel insecure, we have the suture. We have the ability to suture at the same time. We did 174 MACI in total. 50 of them were reported at various meetings. And of the 174 MACI, 48 were arthroscopic. Of the 150 in the knee, a third in the knee, and exactly a third in the ankle. So 1/3 of our cases were done arthroscopic. Really not fair, the statistic, because in the beginning we didn't do anything arthroscopic, and it wasn't until about the first 6 months. The results come out really pretty good. They're very similar to what you've seen, whether you use hyalograph, whether you use chondrogel. You get a hyaline-like cartilage, same thing in the ankle. You get happy patients and a hyaline-like cartilage. You do not get full cartilage. But they do have the very similar, MACI and ACI have exactly identical staining properties. So what you see, your immature chondrocytes, but they're not aligned very well. You see, it's a disorganized disarray. Now, my friend Dr. Henry Mankin at Harvard says this is poo-poo cartilage. But it is hyaline-like, and it stains like hyaline-like, and the patients really don't have too much pain. What I want to show is what we've done with this. So with the extra membrane that we have left over, we were able to look at the cell distribution of the cells in the tissue, and we also looked at failed microfracture when we were doing the transplant, taking out the bad tissue, analyzing it, putting in good tissue, and we looked at the distribution of cells, what the cells look like, and this FGFR3, fibroblastic growth factor receptor number 3, in the presence of absent collagen 2 and 10. Now, what is fibroblastic growth factor receptor number 3? What happened? Okay. This is a picture that hangs in the Prado Museum, and it's not the picture that I want you to see. It's Diego Velázquez. It's truly one of the 5 masterpieces in the world. But if you look in the lower right-hand quarter, there's an achondroplastic dwarf. And these achondroplastic dwarfs have a defect in the ability of this defect in the receptor, a genetic defect in the receptor, fibroblastic growth factor receptor number 3. Now, so far, this has really only been studied in the achondroplastic dwarfs in an attempt to try to cure the dwarfs. But what has happened is when we compared this to failed microfracture and failed other procedures that we do, we find that a healthy cartilage had normal cells, which you would expect, but in the microfracture that is healed with continued pain, there's only 1/3 the amount of cells. There's less than, you can see there's less cells. And when you compare the type 2 collagen, you see that, that on type 2 collagen, the normal is normal tissue, M is the MACI tissue, the R is reparative tissue, the microfracture. You see that the normal and the MACI tissue have the normal amount of collagen type 2, but the microfracture doesn't. That we know, that's already been established. When you look at the collagen type 10, you see just the reverse. The normal and the MACI tissue using Western blot electrophoresis, the MACI and the normal tissue have very little collagen type 10, yet the microfracture has a lot of collagen type 10, and that's why you get the fiber cartilage instead of the normal cartilage. But then when you look at the fibroblastic growth factor receptor type 3, you see that normal cartilage and the MACI cartilage have the normal receptor, but the microfracture doesn't. So one of the things that is limiting us to make normal hyaline cartilage, especially in microfractures, is not only the absence or the less amount of these receptors that we have in this one that we measure, but there are actually more than a dozen, probably a gazillion receptors, and these receptors are nothing more than polypeptides in the cell membrane. And so if we can match the right polypeptides in the cell membrane, we can start to do all kinds of things. So So what we did find, though, was that in MACI chondrocytes and normal chondrocytes, they had the normal amount of collagen type 2, normal collagen type 10, and the normal amount of this receptor. Nobody has ever really looked at this receptor before in failed microfracture or failed or other tissues, or even the MACI. We did have, with results of using the MACI, you wind up with a membrane that's left. So with the membrane that was left, we added a dinucleotide, which is a diadenosine tetraphosphate compound. And what we found was that we can increase the amount of collagen type 2, increase the collagen type 10, and more importantly, we can make extracellular matrix that almost doubles or triples the normal amount of extracellular matrix. Now, if you're going to want to grow something, you need to put topsoil and make it grow in something. And the chondrocytes will grow in the extracellular matrix. So rather than having to wait for the chondrocytes to produce the matrix, this is a way of augmenting it. Looking again at electrophoresis, you can see that we've almost tripled those treated with the diadenosine tetraphosphate has almost tripled the amount of extracellular matrix in the same amount of time. And another graph of a similar thing. So adding a cocktail of polypeptides with our growth factors, it's not just a matter of factors of growth factors, but it's a matter of having a receptor, because if you have a growth factor, and you don't have a receptor, a polypeptide in your cell membrane, that factor is not going to do anything. So we have a lot to do investigation-wise. Showing our MACI statistics after 174 MACI, without prior surgery, if MACI is your first surgery, you have an 89% success rate on a medial femoral condyle. With previous surgery, you're down to 70%. And then with all defects, whether it be patella, medial femoral condyle, bipolar, one defect got 77% good to excellent results. More than one defect was 67%. But the most important thing, without a previous surgery, the results are approximating 90% for good to excellent results with a MACI procedure without kind of screwing up the joint before you do it. This is another published study showing a very similar data to ours. There's virtually no problem with range of motion. It's a very simple procedure. We had 0 periosteal delamination. We've had no rigidity, no stiffness or arthrofibrosis. Now, this is Steinwach's technique, was where he put the membrane on. I mentioned it before. He put the membrane and injected the cells under the membrane. But it turns out, and he got excellent results, and we found that you didn't have to use the periosteum. When they compared periosteum to this chondroguide membrane, the results were just about identical. So moving away from the membrane, we wanted to ask ourselves, well, which cells really do we want? Do we want, if we're going to put cells on a membrane in Clinica Semter, do we want MSCs or do we want chondrocytes? MSCs, multipleural cells. But the reality is that if you take an MSC for cartilage, of every million MSCs, there's only 10 that are really good pluripotent stem cells, and there's just not enough of the stuff that we need. This is just this past March in the Journal of Cartilage, or January of this year. They looked at, this is out of Israel, they looked at bone marrow-derived MSCs compared to adult osteoarthritic chondrocytes. An osteoarthritic chondrocyte we know is sick and really doesn't produce chondrocytes. Yet if they put osteoarthritic chondrocytes on a membrane, then put that into the subchondral area, that grew better than the MSCs. So whether MSCs or chondrocytes are better is still up in the air. We try to attack the problem in a different way. We looked at 15 merino sheep, and we created an articular defect in all of them. On one area, we put 5 million chondrocytes, another area, 1 million chondrocytes, another area, 5 million MSCs, and then we compared it to an area of microfracture and an area of normal. I said we do in 15 sheep. That's a happy sheep. It wasn't happy after we finished with them, though. And what we found we found really nice chondrocytes and really nice mesenchymal cells. But what we really found, with microfracture, we wound up with fibrocartilage that we knew. With mesenchymal cells, we wound up with fibrocartilage, but some mature fibroblasts and some chondral tissue. But with the chondrocytes, they actually did better, 1 million and 5 millions. So when we did it statistically, looking at COL1 and COL2, COL1, well, COL2, which was what do you want, the control was best, which you'd think the normal tissue was best. It was followed by 5 million chondrocytes, followed by 1 million chondrocytes, and mesenchymals, 5 million mesenchymal cells were worse than 1 million chondrocytes. So it seemed to be in the sheep that to produce COL2, collagen 2, and this is a genetic. COL2, for everybody sitting in the audience that's not aware of that, that's the messenger RNA. So if you have COL2, you are producing collagen. You're producing cartilage. If you don't have COL2, you're not. You don't have the messenger RNA for that. And if you look at the COL1, that's your messenger RNA to produce collagen type 1. And you see that the worst was microfracture. Then a little bit better than that was mesenchymal stem cells. Then was 1 million chondrocytes, then 5 million chondrocytes, and then control, which would be normal. But again, the 1 million chondrocytes and the 5 million chondrocytes made less COL1, which we don't want to make, than the mesenchymal cells. So in my own mind, and hopefully you'll all go look in the future, which cell is the best, look at it, look at the literature, try to decide on yourself, because the literature right now is all over the place, and we don't know which is the best, but stem cells are really, really sexy. But understand that of every 1 million stem cells, you're going to get, of your MSCs, you're going to get 10 that are really the ones that we're looking for. Now, from that, we went knowing the chondrocytes, and we knew that 5 million chondrocytes were better than 1 million chondrocytes, and if we were to use the MACI, we'd only be delivering 1 million chondrocytes per square centimeter, and we know that 5 is better. We moved to a different technique. Using the MACI, if you have, for example, a lesion 2 by 3 centimeters, got that? If you use an ACI, if you use the MACI, you're going to use a 2 by 3, that's going to be 6 million cells. However, if you use the ACI under the membrane, you'd get 12 million cells. So is there really, on a 2 by 3 lesion, should you be using an ACI or a MACI? You're going to put twice as many cells if you use the ACI liquid underneath your graft. So for that, we developed our own biolaboratory, because the companies are not set to change their industrial, the way that they produce these and the amount of cells, and to change to go from 1 million cells to 2 million cells or to 5 million cells really requires a whole other study and a lot of industrial strength spending of money to make the study work. The procedure is exactly the same as the ACI with the membrane. We take this membrane, a chondral guide membrane, we then cut it to shape, and then we take our cell suspension that's been previously biopsied and expanded, and now we're going to put up to 25 million cells on that smaller patch to get in a high number of cells. We put the cells on, we let the cells sit for 12 to 15 minutes, and then we fill the defect. And this is a patella, and when we do the patella, we fill the defect and we suture it in, because we don't have enough security of the fibrin glue. The 16 cases is now 41 cases of our new technique since November of last year. And what we did show is that, for time, it shows that the cells are normal. They don't want to make cancer. They want to make more cartilage. They want to make extracellular matrix. And there's no evidence of atypical mitosis. So I think that we're looking in the future of a scaffold plus cells plus a alleged cocktail of polypeptides, which will be not only just the growth factors, but also the receptors for the growth factors, because if you just put growth factors in an area that doesn't have receptors, nothing's going to happen. And these receptors and growth factors really are nothing more than very complex high molecular weight polypeptides. The ACI results have been 70 to 90%. The study will show you Everybody will quote it when they don't want to do an ACI, that ACI is equal to microfracture. This is good at 2 years and at 5 years follow-up. It was a lead article in the journal in, I think, 2004 in March. When they revisited at 5 years, they found out their same result, level 1 study. Then you look at another level 1 study, this one the Houston Award at the Sports Medicine Society, and they're using a chondrocyte that is kind of juiced up in a higher acuity. And they had at 1 year very similar clinical and a little bit better histological, but at 3 years they had superior histological effect and superior clinical outcomes. So and this is their presentation at Sports Medicine. So you have over here in the literature right now, ACI similar to microfracture, ACI superior to mosaic-plasty, ACI is not as good as osteochondral transplantation, and what we really need is further long-term studies. Just a bibliography. We do this, this is actually, just take a look at this, wireless video arthroscopy. I wanted to show a picture of Pedro. I didn't know if he could make it here because he was getting this award earlier in the week. But we now do wireless video arthroscopy with a wireless video camera and a self-contained high-intensity LED light source. And there's no need for a light source cable or a camera cable. And this will, it just takes away so much fuss when you do the surgery. One more time, next year SICOT is in Dubai in November. Beautiful, beautiful city. And in May of this coming May, the International Cartilage Repair Society, where you will have, if you go to that meeting, you will know everything that you need to know about cartilage for the next 2 or 3 years. And you will learn so much about what's happening in the world of cartilage. The technology is changing if you haven't seen now. I had one more video that for sure won't play. But it'd be worthwhile if it comes on. Let's see what happens. Finally. Yeah, here we go. I was a football doctor, soccer doctor, now I'm a football doctor. And thank you.
Yeah.
Yeah, Pedro has
Coming of the finally.
Yeah.
The finally is to message in the injury of the cartilage. Articular cartilage injury of the knee are common in people aged under 35 years.